So the first talk is on fracture mimickers. These are the x-rays that you might see and sometimes get consulted upon or get confused whether there is a fracture or not. So you just need to look at these x-rays. There is no need to take any notes. This is just like an atlas. You just go through the x-rays and see what appears to be fractures, but actually they are not fractures. So we'll look at the radiographic variants, what is normal in kids, but it may be abnormal in adults, and then look at some anatomic variants, and then what are the pitfalls in interpretation. So we have come a long way when it comes to x-rays. The first x-ray was 1895. That was Röntgen's wife, and it was an accidental x-ray. That's his wedding ring that you can see on the right side. This was the first human x-ray, and he won the Nobel Prize for it. And since then, there has been a lot of advancement in the field of radiology. So periostitis of infancy. So in the first 2 to 4 months, if you take an x-ray of a kid, about 30% of them are going to have this periosteal reaction. One may confuse this with a fracture, but it is very common. It's more common in the tibia, followed by femur, and then the humerus. So basically all long bones. And about 35% of patients would have this, and this usually before the age of 4 months. And you need to differentiate this from a fracture, which is more focal periosteal reaction compared to the periostitis of infancy, which is more generalized along the entire shaft of the bone. When it comes to C-spine, the main thing that you may be called upon is a C2 subluxation. What you need to know is that there are variations in cervical spine in kids because of the ossification patterns. So this may look like there is subluxation of C2 over C3, but it's a pseudo-subluxation. The way you know is if you draw a spinal laminar line, which is the line in the back here, and if they are all touching each other along the line, then it's okay, it's not subluxation. If it's a true subluxation, then the spinal laminar line would be broken at the level of C2, if the C2 is subluxed anteriorly. Similarly, the atlantodense interval, sometimes it may appear to be too wide in children, but you need to remember that it's not ossified. So up to 5 millimeters is normal in children, whereas in adults, if it's more than 3, it's considered to be abnormal. So kids have a little bit more space in the atlantodense area. And then there are prevertebral soft tissues, which are more in children as well. So in adults, when we have prevertebral soft tissues, that indicates some pathology, maybe collection of blood or pus or something, but not in kids. These are normal prevertebral tissues. And because of incomplete fusion of the ossification centers, you do see these lines in the x-rays in children, like a bifid spine of the in the C-spine area, or these borders which are smooth and sclerotic are not actually fractures. They are just ossification centers which are waiting to be fused. The ring apophysis is also a normal ossification pattern above and below vertebral body. You can see an example of a 10-year-old girl who is progressing during the puberty, and you can see how the ossification ring is gradually getting ossified, and it finally fuses to the main bone. So if you are called to say whether this is a fracture or not, you need to remember that there is an ossification pattern about the ring apophysis. Same with wedging. A little bit of wedging is common in pediatric age group. It's physiologic. When your anterior height loss is more than 20%, that is when it's pathologic, or that is when there is a fracture. But less than that is physiologic. The normal ossification centers, so there are several centers around the elbow. It's important to know them. And the reason to know them is then you would know whether there is a fracture, whether it's an ossification center, or whether this is an issue. So this is just a mnemonic credo, and that stands for the capitulum, radial head, and the internal condyle, trochlea, olecranon, and the external condyle or the lateral condyle. which is the last one to appear. So here is a 5-year-old boy, and sometimes you don't know what the diagnosis is because everything looks okay on the x-rays. Here I've put a circle of where the pathology is, but only if you know that there should be an ossified medial epicondyle at this age, then you would know that this medial epicondyle is not in the right position. Otherwise, you may think that this is a part of the capitulum. So this patient had a medial epicondyle fracture, which was fixed. So it's important to know at what age the ossification centers appear. And then there could be irregular ossification when it's ossifying. For example, in this x-ray, you can see that the trochlea is appearing to be very rough or very irregular, and that's just because it is still ossifying. So it's an irregular ossification pattern, but it's easy to misdiagnose this as some roughening because of infection or because of previous injury or something if you don't know that at this age patients are going to get some irregular ossification as the trochlea is developing. Similarly, you have the radial head that gets ossified, and you may have small clefts within the epiphysis that may appear to be fractures, but actually it's just an ossification pattern. We already saw trochlea. We have similar examples for olecranon. This is more common around the elbow, so sometimes if it's confusing, it may be better to get a contralateral x-ray so that you know what is normal, what is not. The capitulum, the physis is wider. Early on I was referred a case about a displaced capitular fracture, and they thought that it was wide in the back, and posteriorly there is more widening than anteriorly. So just need to remember the patterns, and there are a lot of ossification patterns around the olecranon. You can have one big apophysis, you can have multiple centers. So when the patient has a trauma, especially fall on an elbow, it may be sometimes confusing whether this is a fracture. Remember, all the ossification centers are usually well-rounded, they have good borders, they are sclerotic, they don't have acute fracture lines. That way you can differentiate that this is not a fracture. And as I said, you can always get a contralateral elbow x-ray to compare it. Irregular ossification versus OCD. This is something that I see so frequently. Patients are referred because they are diagnosed as OCD. Less than 8 years of age, it's not OCD, okay? It is irregular ossification. So OCD, there have been MRI studies done. Less than 8 years of age, it is irregular ossification. Above 12 years of age, it's almost always OCD because the condyles are ossified by then. So if you have irregularity after the age of 12, it is always an OCD unless proven otherwise. In between 8 and 12 depends on the patient and depends on the patient's symptoms, so there is a little bit of a gray area. These are all the patterns which are normal. So you can see like a fracture line in the posterior condyle, you can see some defect, you can see irregularities, or you can see ossicles. These are all different ossification patterns of the femoral condyle, and you need to know about this if you're going to be taking care of pediatric patients. And same with the lateral epicondyle ossification. It appears for a very small time, but if the patient has an injury right around that time, then you are kind of confused whether this is a fracture or this is a normal ossification. So this is normal ossification pattern. You can always look at the soft tissue shadows. You can examine the patient to see where the pain is. Here is an irregular ossification of the humerus. Same with the patella. Sometimes these irregular ossification can be confusing, may look like osteomyelitis. Then there are variants of the epiphysis. Here are cleft epiphysis that may appear to be fracture lines. Here there are spurs. Again, these spurs I see also very commonly in our fracture clinic. Patients are referred for fractures when they actually normal spurs, especially the distal radius. So just remember, these are not all Salter 1 fractures or physeal injuries. These are normal epiphyseal spur. And you should know where the physes are. For all the metacarpals from second to fourth, the physis is distal, except the first metacarpal where the physis is proximal. And the reason to know is because you can get epiphyseal variations, and then it may be mistaken for fractures in an acute setting. So you should know where the normal variations are. You can see that for the first metacarpal, if you know that the physis is almost always proximal, then in this example, you can see that it's distal, and this is just a variation, it's not a fracture. And similarly, at the base of the metacarpal, you can see in the second metacarpal, the physis is completely formed, and then there are clefts or an attempt to make extra physis in the other bones. And these are all variations of development. Pseudoepiphysis is an attempt to make a physis at the other end. Sometimes it may represent a bracket epiphysis or a delta epiphysis, but most of the time these are regular clefts. And if you follow this patient and take an X-ray a year later, you would see that these would ossify and disappear. It is important to note the shape, especially when it comes to distal tibia. The epiphysis can wedge significantly, and it may mimic a fracture. Like sometimes you may think that there is a Tilo fracture in this area, and you may get a CT scan to find out that this was just a normal epiphyseal shape. So just be aware of the wedging of the distal tibial epiphysis. And then you have these humps, which are indentations in the physis. You see the Poland's hump as well as the radius hump, which is around the Lister's tubercle. And this is, if your fracture line goes to this area, there are higher chances of having growth arrest because it's irregular in this area. And again, these are not fractures. These are just the growth plates or the physis, which have different projection when you're taking an X-ray. So you need to remember, especially the proximal humerus, because the physis is shaped like a tent, it may appear to be a fracture on certain views. And I'll show you, these are all three AP view of the shoulder, but the rotation is different. On the left side is external rotation. See the shape of the physis when it's externally rotated. It's a triangular shaped physis, and when it's neutral, it comes to more like a rectangular shape, and when it's internally rotated, it's a different shape. So you might want to just remember how the physis looks, even if you don't remember the rotation, to make sure you know what is normal, what is abnormal. When it comes to fifth metatarsal apophysis, if the line is longitudinal or along the lines of the fifth metatarsal, then that's normal apophysis, it's not a fracture. Typically, when you have a fracture, it would be a transverse fracture where the fracture line would be transverse or perpendicular to the fifth metatarsal. If it's along the line, it's usually a normal apophysis. Same with the fat pad, that you should remember when you have injuries around the elbow, that a posterior fat pad is never normal. When you have anterior fat pad is normal up to a certain range, and if it's significantly excessive, which is called a sail sign, so that is abnormal. So here you can see an example of a sail sign anteriorly, which is too much of a shadow anteriorly, and then a little bit of shadow in the posterior side, which is not normal. This patient came with an MRI, had a fracture. A lot of times these fractures are very small. You don't need MRI or CT scan. You just look at the shadow. You know that something is wrong. As long as you can rule out an intra-articular fracture like a trash lesion, you can just treat them conservative without knowing what fracture it is. And proximal radius fracture is very common, as well as supracondylar fractures. Here is another example where the patient hit his leg, and the X-ray was reported to be normal, but you can see it's not normal, right? There is a fracture line here, and you might want to just check it really closely. And these patients can have initial displacement, can auto-reduce, and can lead to compartment syndrome. So just be careful about some fractures that may appear to be innocuous, but they might signify more injury, because you can see in the back side that you have the vessel is tethered along the metaphysis, so any injury in this area is prone to vascular injuries or compartment syndrome. Accessory ossicles or ossification centers, there are plenty of them. So it's more common along the distal aspect of the limb, along the arm, along the wrist and hand, as well as the foot and the ankle areas. And there are several of them. It comes, mostly you'll get confused around the ankle, because medial malleolar and lateral malleolar injuries are common, and then you may be called, or the X-ray may report that there is a fracture. Now you don't know whether this is a true fracture, an old fracture, just an ossicle, which is a normal variant, so you have to make a clinical decision. But you need to know that there are normal ossicles around the medial and the lateral malleolus. Same with os peroneum, is just the extra ossicle along the base of the fifth metatarsal, as seen on these views. You can get some ossicles along the inferior aspect of the patella. These are normal ossicles, these are not fractures. And the ossicles usually have very good contour, they have good round shapes, sclerotic borders. That's how you can differentiate. Bipartite patella are normal in the superolateral quadrant. I've got a few patients that were referred for fractures, but these are normal variants. Unless you have a superimposing injury on top of this, that does not need to be fixed. How about this? What do you think this is? It is like the navicular in two parts. It's an entity called bipartite navicular, and most of the time this needs conservative treatment. If you try to fix it, very, very high rate of failure. So you need to know what is a fracture and what is just bipartite. Anatomic variants, which can be seen in adults as well. Okay. We have this supracondylar spur that could be seen in certain patients. Now this you can see both in adults as well as in children, and it's a normal spur. It represents, it doesn't represent an osteochondroma, which usually point away from the physis. I'll just look at a couple of examples here for the posteromedial irregularity, because there is a confusion sometimes whether this is a neoplasm or not, and this is because of traction of the adductor and the gastroc. And there have been cases where it would simulate malignancy. For the sake of time, I'll stop here. This is a little bit longer talk because there are a lot of examples, but I'll be happy to share this talk later. We can even post this talk onto, tag with the program in some way so you can have a look at it. There are basically some atlases, which, if you have access or if you have an online, access to those atlas, you can go through them. And there is one which is Keats and one is by my mentor, Crawford. And there are a lot of examples of such mimickers of fractures in those atlas if you have access to those. Right, thank you.